am Jeremy Murtishaw, executive producer of Open Affairs Television, and I'm sitting here with David Riley from the Federal Health Architecture. Welcome.
Thank you.
Dave, could you give us a little background on the Connect initiative, please?
Okay. The Connect initiative is really a federally funded project. It's a collaboration between multiple federal agencies, and it was really their response to this emerging thing that we call the Nationwide Health Information Network. The Office of the National Coordinator began in about 2004 or 5 a series of contracts to try to develop standards that could be used to exchange health data securely and interoperably over the public internet. And so we call that the Nationwide Health Information Network. So in 2008, they were going to do what they called the trial implementations. And so the trial implementations, they awarded 9 contracts to existing health information exchanges with the express intent that they would form a cooperative to define a set of standard services, content specifications, testing methodologies, and a data use and reciprocal support agreement, which would all be fundamental things that you need in order to create this Nationwide Health Information Network. And the federal agencies weren't really involved with that, so they were concerned that these standards would be defined and they would have to live with them without having any say in it.
Sure.
So we pulled together the federal agencies in 2007 over the summer and came up with a strategy, a 4-pronged strategy for them to be able to engage. Mm-hmm. And so we were able to successfully get agreement to execute that strategy on October 12th, and on October 19th of 2007, we became a part of the cooperative, the Federal Health IT Consortium did. And so as a part of their agreement, they agreed that they would abide by all the things that the people who are under contract would, which included not only helping to define these standards, but to implement them, test them, and then demonstrate them. So it meant that not only were they signing up to a lot of meetings, mm-hmm. But they were also signing up to actually creating real software that actually could be deployed and used,
sure.
and that they would have to do the testing as well. And so the Connect initiative was that implementation, and so we led a contract and hired a contractor to develop it, and that work started in March of 2008. And so the initiative is really the collaboration between the federal agencies at one level, mm-hmm. and then it's also software that's being developed.
So how have the commercial EMR EHR vendors responded to and adopted the Connect initiative?
Well, I think the early response is fairly typical of vendors that are trying to decide whether something is threatening and evil or competitive,
yeah, absolutely,
and or something that is good that they can take advantage of. And so, as one of our philosophies, one of our core values is collaboration, and so we tend to partner promiscuously, and I use that term rather liberally when I'm out speaking in public because it has a definite impact. People are kind of shocked by it. But the idea is that anybody who's willing to talk to us or engage us in discussions, we're willing to have those discussions and figure out a way that we can collaborate and work together.
Right.
So as a part of our ongoing efforts of outreach and building the open source community, we have codeathons every quarter. And so we had one in Miami, Florida at FIU last spring, and we had a number of vendors that we invited to that. And so out of that, there was this kind of coalescence of purpose around how do EHRs interoperate using NHIN or Nationwide Health Information Network services and standards. So we have this concept of communities of interest in the open source community that's built around Connect, and so a special interest group formed composed of EHR vendors, and we call it our EHR ISIG, which stands for Electronic Health Record Interoperability Special Interest Group. And so we have right now about 70 of those vendors collaborating together on a specific set of use cases that they're going to create solutions for that we can actually demonstrate at like a HIMSS conference or another big healthcare conference, and then move product into production. So out of that they'll be able to create offerings that they can take to their customer base. So it's been a very positive relationship in moving forward. We've been very happy with the fact that we've been able to engage.
One of the big concerns that I think that people have when they look at the exchange of data, especially PHI data, between healthcare facilities is the security of the data.
Mm-hmm.
What controls and auditing functions are available with Connect, and how would and have you experienced any data breaches since Connect has been available?
Let me answer that question right off the bat. To our knowledge, we have not experienced any data breaches. Nobody's reported any to this point, and we're not aware of any.
Okay.
So that doesn't mean that there may be one that we're just not aware of, but at this point we don't know that. So in terms of security and privacy, obviously those are big deals. We've said that the goal of the Nationwide Health Information Network was to create a set of services for standard services and content standards that could be used to exchange health information, PII, over the public internet. Mm-hmm. So of course there's a lot of hand-wringing and brow knitting over that.
Sure.
Oh my God, how do I know that it's safe? And so there are a set of technical controls and operational controls that so we implement technical controls and we make recommendations about operational controls and physical controls that an organization would put in place to ensure the protection of the data. Fundamentally, we knew that we had to be able to do HIPAA accounting about the release of the information.
Right.
So when we built the authorization framework, which is what we use SAML for, all of the data that we need to be able to do HIPAA accounting reporting about the release of the information is captured as a part of that specification that we have in the authorization framework. So purpose for use, who's asking for it, what was their level of authentication strength, those kinds of things. So all of those things that you would need to have for that HIPAA accountability on a technical level are there. And then from a trust fabric perspective, obviously there's multiple dimensions to trust, and so technical dimension is one of those. Then there's a legal dimension to the trust fabric, and we exercise that in the exchange through the DIRSA, which is the Data Use and Reciprocal Support Agreement. And the DIRSA, you could think of that as a treaty that everyone signs up to. You warrant certain behaviors. There are remedies if you don't behave accordingly. And there are penalties. So if you become a bad actor, you basically can be excommunicated off of the Nationwide Health Information Network as far as the exchange is concerned. And so there are accountabilities that exist there, and everybody's expected to abide by applicable law, which means they have to abide by HIPAA. If you're a federal agency, you have to adhere to FSMA. Mm-hmm. And if there are state laws that are applicable, you have to abide by those as well. So there is a complex web of things to give assurance
Sure.
for what you're talking about. That includes technical controls that at least as a baseline level allow us to be able to create the auditability and the accountability that you're asking about. And so there are ways that you can query for that to find out when was information released, under what purpose for use, and who received it, and you can verify whether they got it or not, those kinds of things.
Now, when data is released from one organization to another, and the viewing physician or mm-hmm. practitioner is allowed to look at the data, and they make changes to that data, is that data also replicated back to the original source?
The current concept of how the exchange takes place is that if you're in organization A and I'm in organization B, if you're doing in the paper world, I would basically get a consent from the patient that gives me the right to ask for the records from you. That's right. I send it over and you would send that over. Once I get that record, I ingest it into my record keeping system, and so the applicable local laws apply, and I have to maintain that record as a part of my record keeping system if I've ingested it in. If you're doing an encounter where you're making decisions on that data, you're really not altering that record per se. You're creating a new record, which is incorporating data from the old record into the new. The idea is that if you have a piece of data that you're making decisions on, you should document it in that current encounter note. So from a technical perspective, we're really not making changes to that.
Okay. Making additions to the chart.
We're making a new encounter note, which
Sure.
I may pull data out of that record. And so I would want to attribute the source of that data. So it's, in my EHR system, I would hope that if I pull a section out of there or some data out of there, cut and paste it or what have you, I can attribute to that that record that it came from that record, and so I'm relying on that data as a part of my decision-making process. Now, there are instances where somebody might come and say, hey, this record is incorrect, and this is the correction, the amendment I want to make to that.
Right.
So there are laws that govern amending or correcting records, and in reality, the change would probably be noted as an amendment to the document that the provider is creating, the new document, and if the provider were following the normal procedure, they would probably refer the patient back to the original office
Sure.
that they came from, so that the record could be corrected there.
Okay.
But if I were the provider seeing the patient and they were saying, oh, that's wrong, I would make a note of it in my chart and recommend that they go contact the other physician to see that they can get that record amended there.
So are you saying that it is a bidirectional exchange of data?
It can be.
Can be.
So electronically, right now we don't have a message set up that says, oh, you need to correct this and send it back to the other doctor's office, or alert them that there is a correction question on the table.
Sure.
It may be that the patient's thinking it's wrong and the doctor would disagree with that. So it's a little bit more complex from an evidential or legal record-keeping perspective.
Correct, right.
Because medical records are evidential records that we use in a court of law. We use them for healthcare delivery, but they are evidence of the services that we've provided. And so you've got to meet the requirements of evidentiality, and you can't violate the integrity of the record. So there are procedures around that. It's a little more complex than what most people initially think about. But
Great.
Yeah.
Well, thank you very much. It's been a
You're
great
welcome.
conversation.
It's been a pleasure.
I'm here with David Riley from the Federal Health Architecture. And this is Jeremy Murtishaw signing off from Open Affairs TV.